My name is Chen. I am the director of the Transplant and Cell Therapy Program at Massachusetts General Hospital in Boston. I have two. All right. I'm going to take advantage of my license and talk about two cases. And one is from years ago, a long-term survivor, and one was recent, and they've both been inspirational to me. So my first case is a fifth. I met her when she was 53. She was a woman who lived in New York City and was unfortunately diagnosed with AML and treated in New York. She did not go into remission with 2 rounds of induction chemotherapy. This is back in 2009. And she was ultimately told there was no other options and referred to hospice. And so she was in a hospice facility. And after 2 months, she was still fine. In fact, nothing really had changed, was not progressing towards death and felt well. So she sought a second opinion with us at that time. This is again back in 2009, and the bone marrow biopsy then showed around 30% myeloblasts consistent with AML. I don't, off the top of my head, remember the exact karyotypical features. We didn't do standard molecular genotyping at that point. We didn't have anything better in terms of what we thought would be reinduction or salvage chemotherapy at that point, but she looked otherwise healthy for a 53-year-old woman. And we actually, took her directly to a myeloablative transplant with primary refractory AML. I mean, there's a literature on this, with a survival rate of somewhere between 5 and 10% of all patients, though there's a lot of definitions of primary refractory. Her early course was complicated by severe acute GI GVHD of the gut and the skin, as well as BK cystitis, and stayed in the hospital for about 4 months, in the first time with her transplant. And she ultimately made a remarkable recovery and stayed in remission. Now, 3 years after that transplant, she suffered a late relapse, unfortunately. And we actually treated her at that. So this is like 2012 now. We actually treated her with high dose lenalidomide and donor lymphocyte infusions, which didn't work. Her disease progressed. And she suggested that we use pomalidomide at that time. At that time, immunomodulators were still an agent we were investigating for AML therapy. So we wrote letters and actually got her pomalidomide. And after 2 cycles, she went into complete remission with pomalidomide. And then I took her to a second allogeneic transplant, this time reduced intensity with a different donor. This is now 2014. At 6 months after that, she developed fairly aggressive chronic graft versus host disease, which ultimately progressed to sclerodermatous disease diffusely. But with the use of ruxolitinib, she's had a complete regression of all her sclerodermatous chronic graft versus host disease, which is unbelievable. She's now 7.5 years out from transplant number 2, and has a decent quality of life and is in remission, and really is just truly an overall remarkable story, and really inspiring to me and other patients. The second patient, 63-year-old Chinese woman with long-standing MDS. She was diagnosed MDS in her 30s when presenting with isolated thrombocytopenia. We don't have the original pathology reports or material to verify that, but this is what we were told. And she ultimately moved to Arizona, had a family, had 3 children, all of whom became physicians. And over the last couple of years, her counts have started to decrease. She ultimately moved to Boston last year to be with her daughter, and ultimately required treatment for MDS due to progressive cytopenias. Where she was treated, they ultimately performed a diagnostic bone marrow biopsy, and next generation sequencing showed among several mutations, there was a GATA2 mutation. It's unclear if this is germline or not, as that testing has not yet been done, but it wouldn't be surprising given her long history of MDS. She developed worsening cytopenias and excess blasts, and she was being treated with the combination of hypomethylating agents and venetoclax. Her brother, who is in Taiwan, was identified as a full match, and he flew over here, and he was his GCSF mobilized peripheral blood stem cells were collected and cryopreserved due to concerns about the ongoing pandemic. And she was ultimately supposed to go to transplant in January of 2020, but developed progressive shortness of breath, hypoxia, and diffuse infiltrates on her imaging. Eventually, after a comprehensive workup, she was diagnosed with pulmonary alveolar proteinosis. Now, this is a known complication of MDS, specifically in patients with GATA2 mutated MDS. It's most well described in patients with a congenital GATA2 mutation. There's a whole series written up by the NCI who've seen kids with congenital GATA2 mutation presenting with alveolar proteinosis. There is a case reported too of patients who have acquired GATA2 mutation and MDS and also developed alveolar proteinosis. And the pathophysiology here is thought to be that you have dysfunctional pulmonary macrophages, partly due to the GATA2 mutation, and they have the inability to clear surfactant in your lungs. And the buildup of surfactant is what leads to PAP, or alveolar proteinosis. At the place she was being treated at, she was started on whole lung lavage to treat her alveolar proteinosis, but she remained quite short of breath. Her DLCO had dropped from a baseline of about 75% of predicted down to 25% of predicted when she developed the PAP. And so they deemed that that she was not a candidate for allogeneic transplant at that point because of this. She came to see us for a second opinion. Fascinating case that we sort of put together as maybe this was alveolar proteinosis from an acquired GATA2 mutation, looking through all her reports. And we didn't truly know what to do. She continued with whole lung lavage, but was on anywhere between 0 and 4 liters of home O2. And clearly the lavage frequencies were becoming more frequent. And she was still being treated with HMA and venetoclax therapy. Once she achieved a reduction in blast count, we knew at that point it was either we sort of have to bite the bullet and go to transplant, or she would probably die soon in the next few months because of her pulmonary condition. With, shall I say, trepidation and full sort of informed consent, I think we had long discussions with the patient and her family. We actually proceeded to a reduced intensity transplant using fludarabine and melphalan, and used her cryopreserved donor's cells as the graft source. I personally viewed her pulmonary comorbidity as dynamic. Now, we know that out of all the organs we look at before transplant, the lung is probably the most important and the most predictive of long-term complications and non-relapse mortality. At the same time, the theory was that if we replace the macrophages here with healthy ones from the donor, then that would fix her pulmonary alveolar proteinosis, and ultimately her lungs would not be a big issue. And so her pulmonary comorbidity here we felt was dynamic. And if we can get past the first month or two here, then ultimately we could hopefully achieve a good outcome. So when she was admitted for transplant, we lavaged her twice during conditioning chemotherapy, right before and right after, and right before her transplant. And her lungs ultimately got tremendously better once she went into her hematological nadir. After engraftment, we did do another lavage just because she was in the hospital and how complicated it was to do procedures during the pandemic. And ultimately she was discharged, and it's incredible. Her lungs have fully recovered. She's 6 months out. She hasn't needed a lung lavage since leaving the hospital. She remains in remission without any graft versus host disease. And so ultimately, while we justified the transplant to cure her MDS, what actually made the biggest difference in her life was fixing her alveolar proteinosis. And it sort of leads to thinking about transplant for conditions where we just need to replace hematopoiesis rather than cure malignancy. And I think this will be an avenue that we explore as we go forward, as we're getting much better at doing transplant.